Hello and welcome to my brief look at non-cyanotic heart defects in my first part of pediatric cardiology. So just a quick overview of congenital heart disorders. All are obviously diagnosed by echo. One way of classifying them is into stenotic lesions, left to right, right to left, and mixing. But there's something called an isomigris phenomenon, which basically screws this classification up. So to start off, I'm going to explain that a left to right shunt, none of the defects with the left to right shunt begin with a T. So that's a really good way to remember them. PDA, ASD, VSD, an endocardial cushion defect, none of those start with a T. However, all the classic right to left lesions do. Patent ductus arteriosus, basically the patent ductus arteriosus causes blood flow from the aorta to the pulmonary artery. An etiology is congenital rubella infection. Size determines severity, so a large one is going to present with a machinery murmur, widened pulse pressure, and a decreased diastolic blood pressure. The chest x-ray is going to be increased pulmonary artery and show pulmonary markings, increased pulmonary markings. The EKG is going to show left ventricular hypertrophy. The ventricular septal defect is the most common of all congenital heart diseases. It can easily jump categories due to the Eisenmenger syndrome. And it's asymptomatic if the PVR stays below the SVR. Otherwise, it shows symptoms associated with poor perfusion, like heart failure, failure to thrive, cyanosis. And when you have the classic severe VSD, you're going to show a severe harsh hollow systolic murmur. So it's going to be present throughout systole, it's going to be harsh, and it's going to be present over the left sternal border. And you're also going to see a wide splitting of S2. However, it's not a wide fixed splitting. The wide fixed splitting you see in ASD. Muscular VSD shows a better prognosis than membranous VSD. And usually you would have a spontaneous closing of the muscular VSD. In the case of membranous, you would probably have surgery in the first year, especially if there is some aberrations in pulmonary blood flow. Atrial septal defect. It's usually caused by defect in the ostium secundum. It doesn't really show symptoms early in life. Someone with an ASD may present with exercise intolerance. There's a systolic ejection murmur along the left mid to upper sternal border. Compare it to the murmur present over the lower sternal border that's hollow systolic in VSD. On the chest x-ray, you're going to have an enlargement of the atrium and ventricle on the right side of the heart. And the electrocardiogram is going to also show the right axis deviation and also show some right ventricular hypertrophy. And last but not least, the endocardial cushion defect, commonly caused by and classically seen in trisomy 21 or Down syndrome. It only has a mild occasional intermittent cyanosis. You can think of it as an ASD plus a VSD plus abnormal valves. It would present with heart failure and failure to thrive. And that's why many people with Down syndrome, the thing that afflicts them and causes a lot of morbidity is the heart failure. Physical examination findings are pretty classical: the precordial bulge, the pulmonary systolic ejection murmur. So that is the end of my lecture on part 1 of pediatric cardiology. Please like and subscribe.